Welcome back, everyone. We're going to continue down the toxicology series with looking at common over-the-counter and household toxidromes. When evaluating a patient, particularly with altered mental status, and we're trying to assess the prevalence or possibility of a potential toxic ingestion, there are lots of things around the home that can create problems for the patient. This includes things like unsecured medications, colorful plants, cleaning products, and cosmetic care. So as we assess the scene and assess the patient, here are a handful of things that we can keep in mind and sort of their implication and presentation to our patients. The first we'll start with are things like hydrocarbons. Hydrocarbons are commonly petroleum products. The toxicity of the hydrocarbon is going to be based on three different characteristics: the viscosity or thickness, the volatility of the substance, and its surface tension. The lower the viscosity of the hydrocarbon, the higher the risk of aspiration will be. And lower viscosity hydrocarbons tend to facilitate the uptake into the central nervous system, and they may produce gastric irritation as well. For assessment and management for these patients, we want to ensure decontamination if it's surface exposure. Establishing and maintaining an airway is going to be important, and for advanced level providers, IV access and ECG monitoring will also be important, along with fluid boluses of normal saline for advanced level providers, and all provider levels should be able to transport these patients to an appropriate facility. Non-prescription pain medications, this is mostly looking at things like NSAIDs or ibuprofen. NSAIDs are nonsteroidal anti-inflammatory, and overdoses, many NSAID overdoses remain asymptomatic and can remain asymptomatic for a significant period of time. At toxic levels, the sign can include things like nausea, vomiting, and abdominal pain, as the toxicity is largely related to the liver. For acute management, establish airway access and vascular access for advanced level providers. Administer supplemental O2 when needed. Advanced providers can treat hypotension with normal saline, as well as treat seizures with benzodiazepines, and then transport to the appropriate facility. Salicylates, or things like aspirin, have a bit of a different clinical presentation, and it can change based on the patient's age, the drug ingested, and the duration of exposure. Overdose in children is typically accidental, while overdose in adults are typically intentional. Assessment and management are supportive: airway and vascular access for advanced level providers, normal saline for hypotension. Monitor carbon dioxide levels, as there might be some respiratory impacts that can occur. Administer activated charcoal if you have standing orders to do so, as it can be helpful in salicylate consumption, and transport to an appropriate facility. Acetaminophen or Tylenol is well tolerated with few side effects. The pathophysiology is that it's rapidly absorbed into the GI tract, and signs and symptoms can occur in 4 different stages. So the table here represents stages 1 through stages 4. Stage 1, with the less than 24 hours, is typically just nausea, vomiting, loss of appetite. Stage 2, so up to 3 days, is starting to result in right upper quadrant pain, typically associated with liver insult, and a tender abdomen to palpation. Stage 3 will be metabolic acidosis with renal failure and coagulopathies, and that can be 72 to 96 hours. And then stage 4 is 4 to 14 days, where liver failure progresses, and patients ultimately can die. This is a very, very painful and long-term pathology for patients who oftentimes with Tylenol overdose have attempted suicide. Recovery is very, very difficult for these patients. For us in the pre-hospital world, management is going to be largely supportive and getting the patient to an appropriate facility. The antidote for Tylenol overdose or acetaminophen overdose is acetylcysteine. Establish the airway and vascular access as needed for recent ingestion. So if it was ingested within the most recent few minutes, you can consider the administration of activated charcoal. Lead is not as prevalent as it once was, but there are still some toxicities related to lead that we may encounter in the pre-hospital world. Most toxic ingestions recur as a result of environmental contamination. Inorganic lead absorption usually occurs within the GI tract, and excretion from the body is slow, while organic lead, once it's in the body, it metabolizes itself into inorganic lead and then triethyl lead. Assessment and management for these patients is associated around symptom presentation management. Try and identify the source. If there's airway compromise, establish and maintain airway, treat hypoxia with oxygenation, and transport to an appropriate facility. Iron has its toxic effects basically reflecting the amount that's ingested. We would typically see iron toxicity with with the excessive consumption of things like children's vitamins that are flavored, where a child got a hold of a big bottle of Flintstones vitamins or similar and consumed a large amount of quantities of that. Generally, within the first 30 minutes to 6 hours, we would see GI symptoms, and those would culminate into later stages, stage 4 and stage 5, where might see hepatic failure, metabolic acidosis, dehydration, and lactic acidosis. Iron poisoning will usually cause symptoms within the first 6 hours. Early stages can include things like vomiting, diarrhea, and abdominal pain, while late stage presentation can include things like profound shock, seizures, hyperthermia, and liver failure. Life support measures include ABC management for these patients at the appropriate level for your certification. Mercury accumulates when consumed, accumulates in the liver, the central nervous system, and the kidneys. The table here at the top right just kind of shows where most of the mercury is found in today's world. Assessment depends on the type of mercury that the patient was exposed to and the route of entry. It typically involves central nervous system, renal, and GI presentations. For primary management for these patients, remove the patient from the source, pay attention to ABCs, and transport to the appropriate facility. Arsenic can enter the body through ingestion, inhalation, absorption of the skin, and it's eliminated or excreted through the kidneys. For acute arsenic poisoning, we would see things like headaches, severe diarrhea, vomiting, sometimes with blood, pain in the abdomen, and chronic exposure would be partial paralysis, numbness in the hands and feet, could be accompanied with blindness and seizures and skin discoloration or thickening. The clinical presentation that we may see in the prehospital world is going to depend on the type, the amount, the concentration, and the rate of absorption and elimination. Symptoms can appear within 30 minutes to several hours and can include a number of things like severe abdominal pain, metal taste in the mouth, general malaise or weakness, rhabdomyolysis, and hypotension. Establish airway and vascular access as needed for these patients and administer saline for hypotension for advanced level providers. We should consider continuous ECG monitoring, and if the patient presents with torsades, paramedics can administer magnesium sulfate to help combat that dysrhythmia. Patients should be transported into the appropriate facility. There are a handful of plants that are poisonous. Approximately 65% of exposures to poisonous plants involve children under the age of 5. And while deaths are rare and ingestion does usually result in minimal symptoms, it's something to be noticeable of. Diphenobacchia is a group of plants that contain calcium oxalate crystals. Caladium is also a popular house plant that contains calcium oxalate crystals and can be toxic to children. Azaleas and rhododendrons can cause cholinergic type symptoms, so simpler, milder versions of symptoms that look a lot like organophosphate toxicity. Latania or red sage or wild sage can also create some complications. Castor beans, chewing just on a few seeds can kill a small child, as ricin can cause a variety of toxic effects. And foxglove is another poisonous plant that's not necessarily common, but can be seen, and it contains cardiac glycosides, and effects much like digitalis. Assessment, get all the information that you can, and contact the Poison Control Center. That's going to be your best resource if your patient is suspected to have consumed a plant. Find out when the plant was ingested, what exactly did they eat, whether that was leaves, stems, roots, etc., and what signs of presentation does the patient have at this point. Most exposures don't require treatment. It's mostly supportive care, but you do want to contact Poison Control Center. A child who is symptomatic should be evaluated by the emergency department and monitored for a period of time. Poisonous mushrooms, there are factors that determine toxic results, including the age of the mushroom, what season it was gathered in, the amount that was ingested, and the preparation method that was used. For assessment, the time of the symptom onset can serve as a predictor for potential severity. If symptom onset was within 2 hours, it's typically not life-threatening, but if it was 6 hours or later, it could be potentially fatal. Most common complaints after ingesting poisonous or toxic mushrooms would be abdominal cramping, diarrhea, vomiting, and GI bleeding. For management for these patients, establish airway and vascular access, administer normal saline for hypotension for advanced level providers, and again, consult poison control. These are a great resource for toxicity. So make sure you're reaching out to these folks and getting the appropriate advice for the specific entity you're looking at for these patients. Food poisoning is when you encounter two or more sick people at the same time. You can suspect food poisoning or carbon monoxide poisoning. Generally, families that eat together and sleep together are exposed to the same products. And so we look at, when we have multiple patients with the same symptoms, something like carbon monoxide toxicity or food poisoning. Food poisoning can be from products that have expired or aren't any good, typically induced diarrhea, intestinal colic. It may accompany a headache. The toxins that produce food poisoning are typically things like listeria, toxoplasma, and salmonella. Poisoning with Clostridium botulinum is usually the result of improper food storage or canning. Onset of signs and symptoms typically range from several hours to days. Most commonly, you're going to start symptom onset about 24 hours after the contaminated food was eaten, and gastrointestinal complaints are the most common. Now, respiratory distress and arrest can occur. They're just not very likely, and respiratory arrest may be due to a more secondary cause such as aspiration. Support airway breathing and oxygenation, establish IV access. Advanced providers may consider fluid boluses for dehydration or antiemetics to help the patients with nausea or emesis.